Hello and good morning. Thank you so much for joining us. I've been following along in the chat. I'm so excited to see all of you here today. Very exciting to see all of the areas of Ohio highlighted. My name is Lindsay Schiavarelli. I'm the director of the Center for Maternal and Young Child Health here at Groundwork, Ohio. Thank you for joining us in an important conversation connecting the dots between maternal mental health and maternal mortality and morbidity. We are going to bring you an impressive lineup today to discuss the link between these issues based on data, research, the connection here in the state of Ohio, and what programming looks like in practice. For those of you who may not be familiar, Groundwork Ohio is a committed, nonpartisan public policy research and advocacy organization formed in 2004 that champions high-quality early learning and healthy development strategies from the prenatal period to age 5 that lay a strong foundation for Ohio kids, families, and communities. We work hard to advance quality early childhood systems in Ohio by engaging, educating, and mobilizing diverse stakeholders and strategic partners to promote data-driven and evidence-based early childhood policies. In the fall of 2021, Groundwork Ohio launched 3 centers of excellence. We have the Center for Family Voice, the Center for Early Learning, and the Center for Maternal and Young Child Health. Each center has unique priorities and concentrations, but provides a collaborative, multidisciplinary, and comprehensive approach to transform policy, remove barriers, and ensure all children and families are ready to thrive. This webinar is a product of the Center for Maternal and Young Child Health, whose mission it is to prepare Ohio for a better future by building and transforming systems that improve maternal and young child health, promote health equity, and prioritize prevention through policy development, research, and collaboration so that all Ohio mothers and young children can thrive. The center works in partnership with the sectors and systems around us to promote health equity and positive outcomes for women, young children, and families. We would like to send a special thank you to our funders and partners, BI3 and Mount Sinai. So thank you for your continued support. A few housekeeping items that you'll see here on this slide. The webinar is being recorded and will be shared out with you after the presentation today, along with the slides and the slide deck that we're using. You are all muted, but we welcome comments, engagement, questions in the chat box. We will have 2 separate opportunities to address your questions, but we also have a packed agenda. So we may not be able to get to every comment, every question, and we'll be sure to follow up individually with you all if you leave your email with your comment or question in the chat box. Just so that we're all on the same page and kind of know what the next hour is going to bring us. Welcome and opening remarks given by yours truly. We are going to have our keynote speaker, Dr. Lindsay Admin, present to us on the case for connection, sort of connecting that maternal mental health with maternal mortality and morbidity. And we have Lisa Holloway from March of Dimes, who's going to give remarks after that. Next slide, please. After a brief question and answer, we're going to go into a panel discussion, which is going to connect service providers, kind of that real life, what do the boots on the ground look like in terms of providing maternal mental health services in this way. And so we are going to get to speak to Becca Alexander of the POEM program, Dr. Angela Neal Barnett of the Spirit of Motherhood program, and Tammy Jones with the Birthing Beautiful Communities program. So we welcome them. And then we will also have a question and answer at the end. Just a reminder to follow us, Groundwork Ohio, on social media. Visit our website for more information or to find out sort of what the centers are working on. We also wanted to kind of give a shout out to those participants on the webinar today. Please follow their work. We know there's lots of amazing things that are happening in this area. So to help ground us in this important conversation, I'd like to introduce our keynote speaker, Dr. Lindsay Admin. Dr. Admin is a practicing obstetrician gynecologist and professor at the University of Michigan. Building on a background in public health, she focuses on addressing racial and ethnic disparities in maternity care and has contributed to recent research on topics such as suicide risk in pregnant and postpartum women and how depression and anxiety may be linked to an increased C-section risk. She remains a fierce educator and advocate of perinatal mood disorders and other maternal mental health complications. Please help me in welcoming Dr. Admin.
That's great. Thank you, Lindsay, for that kind introduction. I am just kind of waiting to see here. So I see my first slide. Is it possible to have presenter mode or not? I thought we might be on presenter mode, but it looks like that might not be the case. Okay. Well, I'm going to get started today. Actually, give me 1 second just to, sorry about this, just pull up my notes. I thought I might have presenter mode on here. It looks like that might not be the case. So I'm just going to pull it up real quick. Sorry, give me 1 second. Here we go, perfect. Okay, great. Okay, no problem. So Lindsay, thank you for that very kind introduction. As Lindsay mentioned, my name is Lindsay Admin. I'm an obstetrician gynecologist and a maternal health researcher at the University of Michigan. And I'm very excited to be here today. And it's so inspiring to see all the folks who have logged in from across the state and country. Next slide, please. So today I'm going to be covering a few topics. First, we'll take a closer look at severe maternal morbidity and mortality in the United States and in Ohio specifically, and then turn our discussion to the growing contribution of perinatal mental health conditions to severe maternal morbidity in the United States, and finally, some solutions for addressing these crises. Next slide, please. I'm going to try to avoid reading my slides today, but this is one that I do want to read. I start almost every presentation with this quote. Maternal mortality is a very sensitive health indicator. All you need to do is look at a country's maternal mortality rate. That's a surrogate for whether a country's health system is functioning. If it works for women, I'm sure it'll work for men. And that's from Margaret Chan, a former Director General of the WHO. Next slide. Great, next slide. As I'm sure you're all aware, the US is the only industrialized nation with a rising maternal mortality rate. In the US, the maternal mortality rate is about 26 deaths per 100,000 live births. In the UK, that number is 9. In Canada, it is just 7. Next slide, please. We also know that maternal mortality is plagued by long-standing disparities by race and ethnicity, geographic location such as rurality, and by income. Disparities in maternal mortality by race are shown here. This is the most recent data provided by the Centers for Disease Control and Prevention. As I'm sure many on this call know, Black mothers have a 3 to 4 times higher risk of dying from pregnancy-related causes compared to non-Hispanic white individuals. And for American Indian and Alaskan Native women, they are at 2 to 3 times higher risk compared to non-Hispanic white individuals. We also know that rural residents face higher risk of maternal mortality. And in unpublished work by our team that is under review right now, we also demonstrate large economic disparities in maternal mortality in the United States. Next slide, please. Maternal mortality review committees have consistently identified that about 2/3 of maternal deaths are preventable. This includes nearly 100% of cases associated with perinatal mental health conditions. Next slide. Although deaths are the most tragic event in obstetrics, severe maternal morbidity or complications of pregnancy and childbirth that have long-standing and long-term negative consequences for an individual's health are estimated to be 70 to 100 times more common. Severe maternal morbidity encompasses a broad range of complications that without prevention and treatment could lead to maternal death. Examples include having a heart attack, needing to use a breathing machine, or having to have a hysterectomy at the time of birth, which is usually the sign of a large hemorrhage. Severe maternal morbidity is studied to understand how to mitigate future cases of maternal morbidity and mortality in the United States. Like maternal mortality, severe maternal morbidity is also rising in the US. Next slide, please. In a recent study by our team, we found substantial racial and ethnic disparities in severe maternal morbidity among births to non-Hispanic Black, Hispanic, Asian or Pacific Islander, and American Indian or Alaskan Native individuals compared to non-Hispanic white individuals in the United States. Next slide. In 2019, our team examined the predicted probability of severe maternal morbidity among rural and urban residents. We found elevated odds of severe maternal morbidity among rural residents during childbirth hospitalizations across the entire study period. Next slide. Perhaps the most important data that has emerged to help the maternal health community address these crises is shown here. Recent data show that the contribution of traditional or obstetric causes to maternal death, such as hemorrhage, hypertensive disorders of pregnancy, and pulmonary or amniotic fluid embolism to maternal mortality is actually declining. This graph shows the declining contribution of those causes over time. Next slide, please. In contrast, the contribution of complications from pre-existing chronic conditions to maternal mortality is rising. Here, increases are shown in the contribution of chronic health conditions to cases of maternal death. Next slide, please. In fact, complications from chronic conditions are the fastest rising cause of maternal mortality in the United States and now account for half of all maternal deaths. I'll get to this in a minute, but when I refer to chronic conditions here, I think at first the maternal health community jumped on cardiac conditions, hypertensive disorders, and heart failure, and other more like traditionally physical health conditions. But there's really an emerging understanding that behavioral health conditions are a chronic health condition that really contribute to these trends. Next slide, please. So another important piece of data has recently emerged, and that's that complications associated with chronic conditions often arise during the postpartum year. The US experiences more late postpartum deaths, so that means occurring between 43 and 365 days after the end of a pregnancy. And we have more postpartum deaths occurring during that period than any other country where there's been data. A third of all pregnancy deaths happen between 43 and 365 days postpartum in the United States. In part, this is because the demographics of our birthing population have changed over time and continue to change. Our team has shown that the prevalence of many chronic physical and behavioral health conditions among individuals giving birth is increasing. Many of these conditions increase the risk for some of the most dangerous pregnancy-related complications, including many pregnancy-related mood disorders, which may not surface until weeks or months after delivery. This means that an increasing proportion of maternal deaths are occurring after pregnancy-related Medicaid coverage ends, which has historically been at 60 days postpartum, and I'll get back to that in a minute. These numbers are even higher for Black individuals who represent a larger proportion of those covered by Medicaid at birth. In states that are able to examine and report on maternal deaths by insurance status, most are among Medicaid beneficiaries. This includes 60% of all cases in Louisiana, 70% of all cases in Texas, and 80% of all cases in West Virginia. Let's take a quick peek here at Ohio's data. Next slide, please. This is data from the Ohio Department of Health, which I'm sure many of you on this call are familiar with. But between 2008 and 2016, there were 610 pregnancy-associated deaths in Ohio. 70% occurred in the postpartum period, and only a small proportion of those happened within the first 6 weeks after pregnancy. Next slide, please. So let's jump a little bit more into the role of perinatal mental health conditions. In an important review of data conducted by the CDC Foundation, The CDC Foundation looked at the results from 14 maternal mortality review committees that had reviewed data between 2008 and 2017. 11% of all pregnancy-related deaths were attributed to underlying perinatal mental health conditions. 65% of these happened in the late postpartum periods, that's beyond that first 43 days, and 100% were deemed to be preventable. Next slide, please. I'd specifically like to highlight some findings related to perinatal mood and anxiety disorders from our team. Perinatal mood and anxiety disorders impact about 1 in 5 individuals giving birth. Our team has showed that individuals with perinatal mood and anxiety disorders experience higher rates of severe maternal morbidity and C-section compared to those without. Our team has also shown recent increases in the prevalence of perinatal mood and anxiety disorders, suicidal ideation, and self-harm among individuals giving birth in the US. Next slide, please. Next slide, perfect, thank you. So this is the data from our team looking at increases in suicidal ideation and self-harm among individuals who gave birth. This is looking at a large commercially insured population, actually. Next slide, please. Moving back to some data from the state of Ohio. In a study just published in the past year in obstetrics and gynecology, researchers examined pregnancy-associated mortality due to accidental drug overdose and suicide in Ohio between 2009 and 2018. The research team found that 6,300 Ohio women of childbearing age died of accidental overdose or suicide during the 10-year period. This included 132 perinatal deaths. They found deaths due to suicide and overdose increased tenfold over the 10-year period. All accidental overdoses in Ohio among individuals either during pregnancy or postpartum included opioids, and half of all suicides among individuals who are either pregnant or postpartum involved firearms. Next slide, please. So let's move on and take a look at some of the steps we can take, and many of you, I'm sure, are taking to address this crisis. Next slide, please. So a little bit more background information. And this is my specific area of focus in my research, is looking at patterns of insurance coverage around the time of pregnancy and different health policies, and sort of evaluating those changes over time in terms of how they may or may not have improved access to perinatal care, including mental health care, and ultimately improving outcomes among individuals giving birth and their children. Health insurance availability and enrollment is a prerequisite in the US really for accessing high quality care before, during, and after pregnancy. Multiple maternal mortality review committees and the CDC have consistently identified lack of access to care as a key contributor to pregnancy-related deaths, particularly deaths associated with perinatal mood and anxiety disorders. Next slide, please. In the US, I just want to review that about half of all births are funded by Medicaid. Based on this map here, in Ohio, that number is about 50%, which is consistent with the national average. Next slide, please. In a study conducted by our team, we looked at the proportion of individuals who had a period of not being insured around the time of pregnancy. So from 1 month before pregnancy to 3 months after pregnancy, that year period. And we found that rates of uninsurance varied by state. Several states stood out as outliers, including Texas, where more than about 50% of mothers reported a period of uninsurance between preconception and 60 days after birth. The reason I'm harping on this insurance thing, and I just want to make sure I've made this connection, is that for a lot of individuals, once they kind of come off of their Medicaid coverage in the postpartum period, that doesn't necessarily mean that their need for management of a behavioral health condition has ended. And that late postpartum period is where we really see individuals struggling to access or continue to access the healthcare they need for management of those conditions. Next slide, please. So I'm going to review very quickly 2 recent policy changes that have impacted, maternal access to care, particularly in that postpartum year. So the Families First Coronavirus Response Act of 2020 required that, it provided enhanced federal funding for state Medicaid agencies to provide care during the COVID-19 public health emergency. State Medicaid programs were required to provide continuous coverage for enrollees. So this is really the first time in the U.S. historically that by default, an unintended consequence of having passed this is that individuals were able to keep their Medicaid insurance coverage beyond those first 60 days postpartum, and in fact, continue to maintain it until the administration decides when the public health emergency is going to end. When the public health emergency ends, coverage will again go back to ending at 60 days postpartum. Next slide, please. The American Rescue Plan Act, passed last April, created a new pathway for states to extend Medicaid coverage through the first year postpartum. This provided federal funding to cover that first year postpartum for a 5-year period, 2020 to 2027. It's estimated that approximately half of all states will adopt this option. Next slide, please. And Ohio, in fact, is one of those states, like Michigan, where I live and work. Next slide, please. Okay, I'd like to just highlight a few other sort of recommendations here. I'm sure these are things that many in this group are working on, or and if anyone has questions about or would like to further discuss any of these things, please reach me by email. But during COVID-19, there were special telehealth benefits to provide care over telehealth. And it would be great if some of those benefits, particularly in the perinatal period and related to perinatal mental health, were continued. So that would be a sort of enhanced way for individuals to connect with care around pregnancy and beyond. Currently in the United States, there is a 5-year sort of period that immigrants to the United States need to wait before being able to be enrolled in Medicaid. One population that has extremely high rates of uninsurance and adverse maternal health outcomes is Spanish-speaking Hispanic individuals in the United States, and it's very likely that a high proportion of those individuals would benefit from this. From a quality standpoint, there's fantastic work going on, and I checked in Ohio specifically related with the following groups: the Alliance for Innovation in Maternal Health. Looks like Ohio has a very active chapter, working with state perinatal quality collaboratives, which also looks like it's in action in Ohio, and then reviewing state maternal mortality review committee works to figure out really where to target programs. Finally, we need better data. Maternal mortality, thankfully, is somewhat rare in any individual state. So there's about 700 deaths per year in the United States. Oftentimes, when looking at small numbers of individuals who have died, it's hard to stratify by race and ethnicity or geographic location because we don't want to identify specific individuals in the data. But it's important that we try to do that where we can. Next slide, please. I think this is my last slide here. And then just specific to behavioral health conditions, co-location of postpartum maternal and infant health services has shown to improve outcomes for individuals with behavioral health conditions. We want to make sure that we continue to try to destigmatize behavioral health conditions, including around the time of pregnancy, and making sure that our care models are culturally congruent. I think if I just have a few more seconds, what I'd like to say is that the severe maternal morbidity measure that I shared has really been developed to track physical health near misses. And what we really need is a way to track behavioral health near misses, things like overdoses, admissions for suicide attempts. And the CDC is actively working on this, and I'm a part of that group. And we're hoping to develop some measures that researchers can look at to figure out what the real burden of behavioral health conditions is around the time of pregnancy, because I think we're missing that in some of the currently developed tracking measures. I think that's it. Next slide, please. So Lindsay kindly shared my email and my Twitter, and I hope to hear from folks in this group, and it was fantastic to talk to you today.
Thank you so much for that insightful conversation, Dr. Admin. I want to encourage you all to type any questions or comments into the chat, and we'll have a brief question and answer after the next presenter. Now I would like to introduce Lisa Holloway, Director of Maternal Infant Health with March of Dimes, to provide remarks. Lisa has a bachelor's in nuclear medicine technology from the University of Cincinnati and an MBA from Xavier University, and she has worked in the maternal child space for 25 years. She currently oversees all program and advocacy activities in Ohio, including the management of the community grants, professional education, and strategic mission investment planning and implementation. She collaborates with many partners, including Ohio Council to Advance Maternal Health, OCPIM, First Year Cleveland, Cradle Cincinnati, FEMUR, Perinatal Community Action Team, and others. So please help me in welcoming Lisa Holloway.
Good morning, everyone. It's a pleasure to be with you. I see lots of friends on the participant list today, so it's really good to be here, and thanks to Groundwork for the invitation. So those of you who know me know that I don't talk about much in 5 minutes or less, and I have 5 minutes this morning. So luckily, we have a lot of information that is overlapped from Dr. Edmonds' presentation, and I'm going to just skip it, but I know the slides are going to go out. So you can all come back and visit them. I will say too that when Lindsay invited me to participate in this conversation, I said I would love to participate. The March of Dimes is trying to be a national leader in this space. We've done some really remarkable work to date, and we're trying to figure out our unique niche here in Ohio to be able to bring people together and further this work, but I am not an expert. So I definitely appreciate the clinical expertise that Dr. Edmond started the conversation with, and I really appreciate all of you on the call who are working in this space directly. Okay, next slide. And I'm going to skip here. So March of Dimes vision, oh, back to that one, I'm sorry. March of Dimes' vision is that we imagine a world where every mom and baby is healthy regardless of wealth, race, gender, or geography. Next slide. These are some foundational setting statistics that you are all well aware of. I'm not going to go through here. Next slide. Our goals at the March of Dimes nationally are to end preventable maternal health risks and death and preventable preterm birth and infant death. We are taking our approach is to really focus in on ending the health equity gap that occurs. And I will tell you that I was just looking at the provisional birth data that was released today, which does show an increase in this country in births, up 1% over 2020, but very concerning that the preterm birth rate has risen 4%. From 10.09 to 10.48, which is the highest preterm birth rate increase since 2007. So, that's important to remember as we're talking about this today, that we are clearly going in the wrong direction on a lot of factors. Next slide. So this slide was already discussed, but I will tell you that increase there is pretty extreme, right? And the U.S. maternal mortality rate has more than doubled from 10.3 per 100,000 live births in 91 to 23.8 in 2014. I'm going to show you even more current data in just a second. So next slide. But I do want to pause here just for a second. Lindsay knows I really struggled with getting my slides together for these comments today because, as I started by saying, I'm not an expert in this space, so I really wanted to dig deep and I really wanted to share information that would be useful to all of you. And I have to say that I really got derailed by the news that came out yesterday of yet another school shooting in this country, which immediately elevated the mental health conversation. And so, I think that all of us on this call, and there's more than 200 of us on this call today, are really, really focused in this space, but there is a lot that we need to really think about and reflect on and come together. These numbers are the most recent pregnancy-related deaths that just came out, maybe a month and a half ago, which shows that we are clearly going in the wrong direction. These numbers are increasing for every group. And are highest for Black women. So, we've been working in the infant mortality space, the maternal mortality space for quite some time. And as we look at the maternal mortality numbers and specifically maternal mental health, we're going to need to really think about things differently than we have in the past, I believe. Next slide. And so one of the things I'm going to talk to you about is the March of Dimes approach with advocacy around maternal mental health. And there's two pieces of current legislation that I'm going to just include here in a minute, but this is part of the brief. These are some statements from the brief that the March of Dimes put together. And I think that they put some context around numbers of families impacted. They attempt to put some cost information around this issue, which I think is also really important, especially as we want our business leaders and our legislative stakeholders to really become engaged and invest resources in this space. Next slide. And so a call out to the Ohio Department of Health. Dr. Edmond mentioned the importance for data, and Ohio is really stepped up in this space. And this report was released, I think, in December of 2019, which really attempted to highlight what was happening in Ohio in the area of pregnancy-related death. I want to just call out on this slide that if you look at pregnancy-related mortality ratios over time, so the graph there that you see that for white women, there's been a decrease, right, between 2008 and 2012 and 13 and 16, but not so much the case for Black women, hardly any improvement there. And so it's encouraging that the Ohio Department of Health is looking at this issue and trying to share data and analyze data so we have a better understanding. And then also, half of these deaths are thought to be preventable. So again, an opportunity here. Next slide. So we've really dug deep here in Ohio. We're doing a project in rural Ohio, and it has really forced us to become more engaged in the work around substance use disorder. But the point here is that in addition to the analysis that the Ohio Department is doing, they are also releasing special topic reports on causes that are factors in the pregnancy-associated deaths. And so this one I think is really compelling, that shows the number of delivery hospitalizations with the drug abuse dependence diagnosis. And you can see here that that number has increased fourfold, is a more than fourfold increased risk of maternal death. So, again, just understanding the numbers and understanding where our opportunities lie, I think is where we need to start. Next slide. I think we can skip this for now, but that the timing related to pregnancy, I think, is important. Dr. Edmond already spoke about the extension of Medicaid. We've been very focused there, and that pie chart depicts the reasons behind the timing. Okay, next slide. We can skip this for now. Next slide. Next slide. And so I wanted to offer you an opportunity to connect with March of Dimes. I will tell you that I think one of our strengths right now in this space is being a national and state advocate for policies that can impact funding resources on a national level that, of course, then will help our states address this issue and more thoroughly. And so we have an action network. You can sign up for action alerts. All this information is available on our website. Next slide. So one of the things that you will find on our website, which I think is probably most important to this call today, is the toolkit for maternal mental health advocates. And there is a lot of information there. You can see some of the inclusions of the fact sheet, the talking points, and you can download it directly. So a tool really to help if you're interested in talking to legislators in this space. Next slide. And so these are the two pieces of legislation that I mentioned that are currently being considered. And so the Into the Light for Maternal Mental Health would expand HRSA's grant program for screening and treatment from 7 states to 25 states and add a hotline. So that's exciting. And then the Triumph for New Moms Act is also a piece that would add a task force that would address maternal mental health issues such as depression, anxiety, suicide, et cetera, and would help develop a national strategy again. So elevating this on the national level is really important as states seek resources to increase work at the state level. Next slide. March of Dimes has lots of professional education that has CEs, CNEs, CEs attached to it. Here are some of the topics that I thought would be relevant for the topic today. And so reducing stigma related to maternal mental health and substance disorder, maternal mental health, all these are available online. We occasionally offer them as webinars or as individual trainings at specific organizations, but just to give you a flavor, I would encourage you to visit if you're interested in topics and looking for continuing education. And then there's always been a specific focus on parents and their stays in the NICU, realizing that's a very stressful time. So there's topics that are specific there. Next slide. Almost done. So our website is a tremendous source of information, not only for providers, but for families who may be seeking information and, just trying to gauge, how they're feeling and, give them encouragement for reaching out to providers. So I would just encourage you to check that out and see if there's something there that might be useful for you to pass along to patients. Next slide. So this is past, this occurred last week, but March of Dimes also offers lots of live events for families to not only hear from experts in sort of a panel way, but also to connect with others. And again, this was available through our Facebook Live page, but I would encourage you to engage to our website for more information. Next slide. Which I think is my last slide. So again, just lots of information coming out on the national level around this topic. I'm trying to pay attention. I'm trying to share it outward. I would encourage you, just to register for some of these electronic websites, newsletters, things like that. And you'll get this information, and there's quite a bit, and it's really exciting to see. Next slide is just my contact information. You're welcome to reach out to me. Again, we're trying to figure out in Ohio what our niche is in this space. And that's probably convening all of the experts, people who want to make a difference for moms and babies with specific respects to maternal mental health. So again, thank you for the invitation today. That was the fastest I've talked in a very long time. I feel like my heart is racing, but again, great opportunity, and thank you. And please feel free to reach out.
Thank you so much, Lisa, for that. That was wonderful. I'm just going to take a few questions from the chat. There are a lot of great recommendations and points that have been made in the chat. And so we will post some of that information in the post-webinar email that you all will get, which will include the slideshow that's been presented today. That was one question. So that will come via email after the webinar. I have a question from Catherine. Is there any work going into looking at young women's conditions that could affect their pregnancies in the future? So I don't know if anyone, Lisa or Dr. Admin, have any thoughts about that.
Sorry, the question was about young women and future pregnancy health. So there was actually a fantastic study in the Green Journal of Obstetrics and Gynecology this month looking at the health of adolescents giving birth. And unfortunately, they found some real parallels with respect to rising rates of chronic health conditions, both physical and behavioral health conditions. And I was able to sort of write an editorial about how important and scary that information is, not only for future pregnancies, but for health of sort of the next generation of middle-aged women. And I'm happy to share that with Lindsay. Maybe she can send it to the group.
That would be great. If we're not able to get to all of your questions, please know there'll be another question and answer at the end of the presentation. And I would like to go ahead now and transition us to a discussion with those working alongside pregnant and postpartum mothers with maternal mental health complications to hear how they are uniquely providing services in ways that meet the needs of their community. First, let me introduce Dr. Angela Neal Barnett, founder of the Spirit of Motherhood program, which screens and treats Black expectant mothers for post-traumatic stress disorder and chronic stress with a community-based and multi-generational approach. Based out of Kent State University, where Dr. Neal Barnett is a professor, author, and director of PRADA, which is the Program for Research on Anxiety Disorders Among African Americans. The Spirit of Motherhood program serves Cuyahoga and Summit counties. Our next panelist is Becca Alexander, the Senior Manager of Statewide Operations at POEM of Mental Health America of Ohio. Becca started with the organization as a support group facilitator and volunteer with the Perinatal Outreach and Encouragement for Moms, or POEM program, after her own experience with postpartum depression and anxiety. Becca oversees programming such as mom-to-mom support and peer mentoring and support groups. POEM has a strong presence in Central Ohio, but supports programs across the state. And our final panelist is Tammy S. Jones from Birthing Beautiful Communities, providing services in the Cleveland and Akron areas. Tammy is the Senior Director of Programs and Behavioral Health, as well as the Peer Support Coordinator. Birthing Beautiful Communities is deeply rooted in the neighborhoods it serves and assists Black women highest at risk for infant and maternal mortality by providing peer-to-peer and doula support, among many others. So please help me in welcoming our panelists today. I'm going to go ahead and just ask you questions kind of one by one. So Dr. Neal Barnett, can you describe the current programming within the Spirit of Motherhood and share the outcomes you have seen impacted through your work?
Sure. Spirit of Motherhood is a multi-generational, multi-level program that focuses on trauma and post-traumatic stress disorder, PTSD, among Black women. The program starts with a screening for trauma and PTSD. There then is a brief intervention that we do in terms of PTSD. Then there is a culturally competent parenting program that we do. We do that because what we continually heard from the mothers was that parenting was trauma and a burden. And so we wanted to reduce some of that burden that they perceived parenting to be. And then the next part is a musical intervention that we do with the preschool children of these mothers. And we recognize that not all of our mothers have preschool children, but the music intervention really helps them as well, because what it does is it reinforces the parenting skills that they're learning in the culturally competent parenting program. What have been the outcomes? Well, first of all, PTSD screening should be mandatory, particularly for Black women. Black women are 3 to 4 times higher to have these traumatic events. The trauma goes unrecognized and untreated for years. Secondly, the need for culturally competent therapists, interventionists. Many of these women have been in therapy before. It's not been as helpful as they would like, and we see them making great progress. We see a reduction of trauma symptoms based on what we do. And then the third one, which was just surprising to us, is that the interaction of cultural mistrust and healthcare provider communication or miscommunication really creates these traumatic experiences for Black women in the birthing process. So a third of the women who are in our program, the trauma occurred as they were entering the hospital to give birth or after they gave birth. So I was being succinct because I want to make sure that we get to hear from all of the panelists today.
Yes, I appreciate that. Thank you so much. I'm going to move on to Becca. Becca, can you share how your personal experience with postpartum mental health challenges has better equipped you to provide services to moms in the POEM program?
Yeah, absolutely. And thanks for having me today. Really appreciate being able to share. So, you know, I'm an Ohio certified peer recovery supporter, and I think a lot of people know what that is and some people don't. So I am a person with lived experience of postpartum depression and anxiety. I have 2 children and experienced it after both children. And I think that particularly as a peer, as somebody with lived experience, I can provide an opportunity for people to engage with care, with community, and with support. You know, pregnant and birthing people don't talk about this. They don't have these conversations. And I think the beauty of peer support and the beauty of what programs like POEM and RISE do is connect people with lived experience so that they feel more comfortable sharing these experiences. And just even to shadow back to what Dr. Neal Barnett said, as far as, trauma and these kinds of experiences, a lot of times that occur through structural racism in healthcare. These are not conversations that people want to have with just anyone. So I think that peer support is really the future of connecting pregnant and birthing individuals with care and support and helping them find their communities. Me as a person who did not have much support or community when I had my first child, my lifeline was peer support. Being able to talk to somebody who knew or had some idea of what I was experiencing absolutely saved my life. And I think that, I've seen that happen time and time again, where, there are things that individuals won't disclose just to anybody, but they will disclose to a peer. And I think this is particularly important when we talk about pregnant and birthing individuals who are experiencing a substance use disorder. Having a peer in between clinical care and the client or patient can make a difference between disclosure and non-disclosure. So, I think it's particularly true for any type of mental health conversation, particularly in some communities where there is much more stigma related to mental health conversations or different ways to refer to what mental health looks like. It's absolutely imperative that somebody is there to have those conversations with that pregnant and birthing people feel like they can identify with and trust. And trust is really the name of the game. So I think that's what equips me, but that's also what equips the rest of the folks who serve individuals through POEM and other peer support programs. Is trust makes the difference between entry to care and non-entry to care. I mean, I think that research is pretty indicative of that. And I think that the work we do in our outcomes definitely is indicative of that as well.
Thank you so much for that, Becca. And thank you for sharing your story. It's being echoed in the chat as well. So Tammy, Birthing Beautiful Communities is an organization rooted in the neighborhoods and communities in which it started and continues to serve. Can you share more about the structure of BBC and how that helps you to serve your community?
Yes, good morning. Thank you for the invitation. So here at Birthing Beautiful Communities, we are a collective of individuals who are doulas. So we train, support perinatal support professionals who are known as doulas. What they do is support our moms from the time they become a client with us until the child becomes 1 year old. So we advocate with the mom. We make sure that we're there in the delivery room with them. We make sure that they have a voice when they're speaking with their medical team. And also, we help them through pregnancy. We help them with parenting classes. We offer classes 3 times a week. The classes that postpartum moms classes, and most importantly, the program that I'm working with is, assisting them with dealing with anxiety, stress, and depression. So we all know that toxic stress is it's a trigger, for moms not being able to deliver healthy babies. So therefore, we want to reduce and eliminate that within our moms. So we have a special program called our Wellness Network, which is a collective of about 35 lay persons and therapists who are trained as grief recovery support specialists. It is an emotional health educational program where we deal with grief. And it is 8 weeks in sessions. We go through this with the ladies. Now, when we get them connected to the program, most of them say, I'm not dealing with grief. There's no grief. But those who have lost a baby, those who have lost a spouse, any other, there are like over 40 different losses that we deal with. So therefore, those losses and that grief is buried. And so because of that, we're dealing with anxiety, we're dealing with depression, we're dealing with stress. There's stress because of toxic relationships, domestic violence, dealing with finances because we can't find a job or we're underemployed and don't have enough money to pay our bills. So therefore, we come in with this program. And not all of them accept this program. Let's just be honest. They're like, oh, I'm not dealing with grief. I have no anxiety. I have no depression. But piggybacking off of Becca, as a peer supporter, you just talk to them. You talk to them about your experiences and you get them to open up and like, oh, wow, I am dealing with that. How can you help me overcome that? And that's what we're doing. Our program is very unique. I love the program that we're offering grief support. And not only starting in June, not only will we be offering this for our clients, and we serve Cuyahoga County and Summit County, we're going to offer this for our perinatal support doulas. What I have found is that they are dealing with toxic stress. They're dealing with anxiety and depression because of their experiences with birth. So in order for them to really help our clients succeed and overcome, we need to have them also address their grief. So we will be making sure that our entire team goes through the Grief Recovery Institute training, making sure that they are able to address their issues so they can be a better support and be able to assist our clients as well.
That's great. Thank you all so much. And I know we're getting a little close on time, but I know that I attend webinars all the time and I'm always thinking, what's my takeaway? What's my action step after this? So I have to ask this one and we'll try our best to keep it as brief as possible. But what I want participants of this webinar to take away with them regarding the connection between maternal mental health and maternal mortality and morbidity. And what's one step that state policymakers can take to support mothers and families? So what's your takeaway for everyone today? Dr. Neal Barnett, would you like to start again?
Sure. This is not the way it's supposed to be, is my takeaway from this. And this is what the women say to us. As we're screening them, as we're talking with them, this has a name. This is, I just thought this was the way it was supposed to be. So the policy I believe the policy should be that maternal mental health is as important as maternal health, and that it should be part of the services that every pregnant woman in the state, in the country receives, and that we need to work towards making that happen, particularly for Black women who are at higher risk for many of these mental health disorders, and what that means for their bodies and what that means for their children.
Fantastic. Lots of support in the chat as well. Becca, would you like to go next?
Sure. Really hard not to just put my hands in the air at those comments, Dr. Neal Barnett. I really think that everybody here probably feels similarly. But, to kind of build from what you're sharing, which I think is particularly important, is what matters and what makes a huge difference for individuals, whether it's seeking care or seeking support, is to have community contact, to have peer contact. So, I would say a really important way we need to move forward is ensuring that pregnant and birthing people have culturally responsive, culturally matched, circumstantially matched, which is not a word we use a lot, but I think it matters, care, support, and peer support specifically within the perinatal period. It's not just about treatment entry. So I really just, want to really emphasize that, treatment is a piece of a very large puzzle that involves community support and involves behavioral intervention that really needs to be in place for people in order to feel supported, to feel better, and to be able to parent the way that they want to parent. So I really just always am wanting to emphasize that, peer support is what makes a difference. It makes a difference in individuals feeling comfortable to pursue a course of treatment, to engage with their recovery, and to share their story. And just like Tammy shared, to feel like they are able to acknowledge their grief, to acknowledge how they feel, and to feel safe in doing so.
Absolutely. Thank you. Tammy, would you like to finish this out?
Yes, sure. We need to normalize mental health. It's not a disease. It is not something that you touch me and it's going to jump off on me, jump off on you. So it needs to be part of care. And we need to reduce the stigma around our conversations of mental health. I would say that me personally, for years, I was afraid and ashamed to say that I was dealing with mental health issues. For one, I wouldn't have said that. I wouldn't have said, oh, I have anxiety, I have depression, because it was a stigma around it. It was taboo. But now, I don't want to say I pride myself in being able to say, oh, I'm successful. I'm an African-American woman. I have degrees. But yes, at times I come home and I want to sit in a dark room and not conversate with anyone. So therefore, I want to share my experience with birthing moms, women across the world, and say that it is okay to not be okay. And it is even better to be able to say, I need help and I'm going to get help. And I am not ashamed. So we need to stop shaming our people and stigmatizing mental health. We have dealt with 2 years of being in a pandemic of COVID. And what were people going through in those 2 years? I know what I was going through. So what was our birthing moms going through? Sitting there alone by themselves, trying to raise a baby or trying to be okay during our pregnancy. So therefore, I really want policies to really include mental health as part of our normal care that we receive.
Yes, thank you all so much. Such great insight. We do have a lot of questions and comments in the chat. I'm going to go ahead and reserve those. We will look into resources. I'll reach out to our panelists and presenters today for additional information, and we'll share out on those in the email that will come after the presentation, which again will include slides, a recording of the video or of the webinar, excuse me, contact information, emails. I saw that in the chat as well. So we'll kind of do a very well-rounded follow-up afterwards. I do want to just take a second to thank you all, thank the advocates and partners in the room today. We are definitely hopeful that this conversation gives you some things to think about or some action steps that you can take in your everyday work to support the mental and physical health of Ohio's pregnant and parenting mothers. As Groundwork Ohio's Center for Maternal and Young Child Health continues the conversation on maternal mental health, we invite you to join us as a partner and an ally. For more information on Groundwork Ohio or the Center for Maternal and Young Child Health, you can visit our website, which is listed here on the slide. And I appreciate you all joining us today. Thank you so much. And I will go ahead and close. Have a good day, everyone.